to catch up you today. Did you like?
Take me home with you.
Yeah. Okay. Let me start before that. I think this is coming up.
Slowly, Fatih, you start speaking.
Okay. Okay. I'm the chairman of the Young Surgeons Committee. How many of you know about Young Surgeons Committee? Have you ever heard about it? Okay, so this picture say me that we have to work more because this is a committee which is functioning for more than 5 years. And this is established for our young colleagues to attract them to the SICOT and to make some contributions to SICOT activities. Who is young? This is the question, of course. Everybody here I saw is young. Of course, I don't want to say something else. Okay, thank you. Thank you. But formally, we accept the surgeons under 40 years old as young, and we want to contribute, we want to employ them in SICOT activities. I will very fastly, quickly summarize some of our activities. I think it's not working.
I'll do it for you forward. इसको निकाल
I think the USB stick is at the other side, that's why.
Okay, should we take it out and do it manually? इसको निकाल के manually.
Sorry for this technical problems. Yes, we formally accept the surgeons under 40, and we want to make them active with some very traditional and very modern methods to come up with, and they are active in SICOT by this way. Is it working now?
Try it.
Okay. Now, these are the members. Now we have 18 members by this year, and some of the members are retired, like Wikas. He had great job with, he had great job in Young Surgeons Committee, but this is a very dynamic group. Someone come and someone go every year, but we want everybody to be active, and we are very open to people, and we want them to really make active contribution. Please, all of you are very welcome to our meeting and symposium, which will be held tomorrow. The formal regulations are for sure not important. We'll be very happy to hear you, because most of you are young or either seniors of the young surgeons. So we will be more than happy to see your suggestions about our activities. We have some new developments and progressions in our committee. This is one of it. Is we make some subcommittees. We constitute subcommittees, but something are different that you see now in the screen. But most of our activities are allocated to some people who are willing to do that. But except the Educational Day, now Educational Day is another activity which will have its own committee, so we'll be work in another avenue after now. But briefly, this is our activities, which I will explain very quickly to you in a few minutes. Signal. This is our e-library. We launched this e-library 2 years ago. You can find it in our SICOT webpage. We are trying to collect all our presentations during the congresses try to record them in a high quality, audio-visual quality, and we put it into our e-library. And these educational days are also recorded and put into e-library. And we have some other projects about enriching our e-library in a few years. So it will be very useful and very, good and easily accessible instrument for you for education. This is the appearance of our Signal webpage that you can really find in a SICOT webpage. This is a very, a simple appearance webpage, and you can either make a quick search from here with some keywords, or you can make some advanced search based on the topic, the subtopic that you are looking for. For example, let's say arthroscopy or arthroplasty or hip or knee, depends. So we have an algorithm which categorizes all the presentations in this e-library. I hope you are aware of our webinars. We announced them from our email groups and from the SICOT emails. Until now, SICOT and WUMEDI collaboration made 4 webinars. These are all was really very good webinars and followed by many surgeons from all around the world. You see some numbers, how much people watch that webinars here. So it's around thousands. Last one was done very recently, so I don't have the data about that. But most of them are followed by many of our surgeons, and the feedback is really excellent, that we are very happy about that, and we will continue to make new webinars in not in very regular manner, but at least in 2 monthly basis. We will continue to make webinars in 2014 and 15 and go on. And we have some conference activities. One of our conference activity is Meet with Experts. This is the interactive session. You can follow it you can find it in our program this year. It will be about arthroscopy and knee. This will be an interactive session and will be discussed with highly top-line experts and the attendees. There will be some young surgeons. They will present some cases, and the experts and you, the attendees, will discuss about those cases. The other is the trainees conference. This is also another satellite conference, mostly done annually, but it's not very regular. But the next one will be planned in soon, and we will make it with our young colleagues. We use social media a lot. Now we are active in Facebook. We are very active in Facebook. We have a lot of followers from India, fortunately, and we are very happy to see that. Now we have around 950 members, but the graphics trend is increasing very explosively. So it's a very good platform to discuss your cases. I really suggest you to be a part of that, and there is no, of course, any limit or any rule. Just to be an orthopedic surgeon is enough to be there. So we will be very happy to see your cases and discuss this, or just you want to share, not to discuss. You can just put your cases, interesting cases, and let us know about that. And our goals. First, now our goal for the near future is to meet more with more young surgeons. Please just help us about this. When we will be more powerful, then all of us will find more educational activities for for ourselves and for our young colleagues in SICOT. So I hope now you know what Young Surgeons Committee is doing. So we will be happy to welcome you in our meeting tomorrow at the symposium. We'll be happy to see you there and your young colleagues. Thank you very much.
Any questions anybody's got about the Young Surgeons Committee?
What you expect elder one to do for this?
Send your
Oh.
youngsters.
We don't, actually, it is really difficult to define someone as old, especially when we're talking about surgeons. But what we expect from all of you is to just really share your suggestions with us. We need your experience, we need your ideas. That will help us a lot.
Yes, please.
Is there any special requirements beyond?
For involving to Young Surgeons Committee, yes. Formally, unfortunately, we have to say under 40 age limit is now a limitation. The other thing is to participate at least 2 sequential congress and to involve to our symposium at those 2 congresses. And this is a subjective, not very objective rule, regulation, but to be active, of course, to be in a subcommittee and make some great contributions for our committee, for SICOT. There's no other rule.
Thank you very much, Fateh.
Thank
Thank you. Thanks a ton. Okay, so it's my pleasure to introduce Professor Mandeep Dhillon from India. He works at the Postgraduate Institute. He works at the Postgraduate Institute up in Chandigarh, which is in North India. He's also the president of the Indian Foot and Ankle Society, also the president of the Indian Arthroplasty Society, publishes almost 1 paper a week and 1 book a month, and he's the chap who never sleeps. So pleasure to invite him. And his task for this afternoon is going to be to make sure that we finish the foot and ankle bit in 1 hour. So good luck, Mandeep.
Thank you, folks. You have my permission to sleep. That's allowed. So I'll pick and choose. But what we're going to talk about is ankle fractures as the first part of the foot and ankle subject. In this little talk, I'm going to be looking at the classification, which is important, the pathomechanics of injury, which were more important when we were trying to do close reductions, and what are the treatment principles today in modern times. Whenever there's an ankle injury, you get injury either in the bone or in the ligament. And this can happen on the medial side, bony or ligament, lateral side, the anterior aspect or the posterior aspect. Or they could all happen as a combination of injuries together. Log Hansen actually brought in a classification which looks at many things. Now, supination and pronation means the position of the foot when the ankle fracture happens. That's important to understand. Adduction, abduction, external rotation is the direction in which the talus moves when it is causing the fracture. So I will be explaining these in sequence as we go along. So remember, supination, pronation is the position of the foot, and adduction, abduction, external rotation is the direction of movement of the talus. So when this happens, the movement of the talus can cause 4 fracture patterns. We'll go over them one by one. Supination, adduction. Firstly, the lateral ligaments are pulled off. Then the displacing talus pushes off the medial malleolus. Pull off of the lateral structures, push off of the medial structures. This is equivalent most times to a Weber A injury. That's a supination adduction injury. Now, a supination external rotation. Supinated foot, external rotation of the talus. What happens is the anterolateral ankle goes first, then the distal fibula, posterior lateral ankle. Lastly, there is a pull-off fracture of the medial malleolus. Supinated foot, external rotation. So this usually becomes a Weber type B injury. Now we have the pronation. This is an example of the supination external rotation injury, which is perhaps the commonest pattern of injuries at the ankle. Pronated foot, talus goes into abduction. The medial injury pull-off happens first. There is disruption of the inferior syndesmosis, and there is an axial or bending fracture of the fibula. So there is almost always, or to a large extent, comminution above the syndesmosis. And the interosseous ligament membrane is injured to that level. So if you look at the X-ray, it's probably going to look like this, with a significantly displaced fracture. Pronation external rotation is similar, but instead of a bending force, there is a torsional force in the distal fibula. The medial injury first, anterior syndesmosis, and a rotational injury of the fibula, which breaks it and disrupts it. And this is a Weber type C. And you could get patterns like this, where you could have purely soft tissue injuries at the ankle and a spiral or a comminuted fracture in the fibula. And sometimes you could have a high fibula fracture. That X-ray didn't work. But if you look at Weber's classification, it is A, infrasyndesmotic, B, transsyndesmotic, and C, suprasyndesmotic. Now comes the treatment. Whatever the treatment we've been telling you all day, look at the soft tissues, do a proper clinical examination, look at associated fractures and associated disease process. A fracture in a diabetic is a bad scenario. Don't miss out on something which can give you problems when you're going in to operate. And then get good radiographs. Most times, good ankle views would help. But if in doubt, get a CT scan. What about management without surgery? Very limited indications, because unfrequently you'll get an undisplaced fracture which is stable, or you'll get an isolated medial malleolus fracture or something. Most times you do non-operative treatment when the patient is unfit for surgery or the limb is unfit for surgery because of a local condition over there. And in these kind of scenarios, you can do the standard so-called closed reduction and apply your POP cast, but follow this patient up on X-rays almost weekly. Because if there is a tendency for this to displace, then what you have to do is surgical intervention, which is done most often in ankle fractures because they are unstables and closed reduction often fails. Timing is important. You cannot operate when the soft tissues are bad. If there is a dislocation of the talus, do a closed reduction, reduce the joint and wait till the soft tissues heal, and then you plan. You have to plan the implant, the patient position, the approaches, the sequence of reduction and fixation, and look after what the pitfalls and hazards are. This is the one joint where you would need to approach from two sides, the medial and the lateral. So you position your patient in such a way that you can get good X-rays and you can approach from both sides. And then the principles of fixation vary. All four fixations could be different, and we look at them individually. On the medial side, it's usually not comminuted, and you could reduce the fracture and fix them with screws under compression, malleolar screws or whatever screws you do. And if the fragments are smaller, you could go in and apply the so-called tension band principles. They are not tension band principles because there are no muscles actively acting on this, but you get compression with the tension band, which is not dynamic, but it is static. Sometimes the vertically oriented fractures may need compression and buttressing, and the adduction injuries, often the corner is impacted, you may need to bring it down and then fix it under stable fixation. On the lateral malleolus, getting the length and rotation is very, very important. So you reduce the fracture after and check it on X-rays, and then you fix it with an interfragmentary compression screw. You will get rigid fixation, and then you can neutralize it with a neutralization plate, and then do the medial side whatever you want to do. The plate can also be applied as an anti-glide plate if you find that the fragment is too small to hold the screws, or in the smaller screws, there are people who are using longitudinal sort of screws or specially designed hook plates. If you have a C1, C2, C3 fracture with comminution, then you need to get a bridge plate there to get the length rotation of the fibula right. And sometimes you really have to not open the medial side if it's a soft tissue injury on its own. Posterior malleolus, there's a lot of discussion. But I tell you, it is safer to fix it if you are in doubt. But if you want the figures, it's 25% or 2 millimeter displacement, and you can fix it percutaneously from the front to back, or with screws from the back to front when you are doing the fibula, which is slightly more difficult and technically demanding, but it should be stabilized if you are in doubt. And there are various ways, and if you leave it and you want to go back in again, it's that much more difficult. Syndesmosis fixation is often the key in Weber C, rarely in Weber B fractures. If it is unstable, you look at the radiographs to see the space between the tibia and the talus, the fibula clear space, identify it, and then you can do an intraoperative stress test, so-called hook test. After you fix the fibula, you try and pull it away from the tibia. If it moves, it is unstable, but then it depends how much movement, and then you've got to go in and fix these. How do you fix it is, you must stabilize it, but not under compression. And you have to put the screw in the right direction, not dead transversely at about 30 degrees angle from the horizontal. People use 1 or 2 screws, large or small fragment screws, whether 3 cortices, 4 cortices. People are starting using tight rope. The key is you must fix it above the joint, not through the joint. And whether you remove it or you don't remove it before weight bearing, I don't think it matters, because the evidence says both things work at the same time. Question comes up, medial or lateral first? If the fibula can be brought back to length and rotation and fixed, the lateral should be fixed first and the medial subsequently. And the aftercare is standard. You can get them a short leg cast, and weight bearing depends upon the injury pattern. If in doubt, delay weight bearing for a short time. So in summary, folks, remember, these are intra-articular fractures in a weight bearing joint. If we understand the injury mechanics and the soft tissues around it, we could restore stability and congruency of the joints. We can aim to get a painless weight bearing gait. Thank you. May I now invite Krish Virupali from the U to give his talk on fractures of the talus. We'll have questions at the end of the session, folks.
Good afternoon, everyone. Good afternoon, everyone. I'm going to talk about talus fractures. Just to give you a brief history, in 1919, Anderson, a consultant from Royal Flying Corps, has coined the word aviatus astragalus. Later on in World War II, Coltart has supported the data of Anderson. 1952, Wildener has described the blood supply, and 1970, we all know about the Hawkins classification, who has classified the talus neck fractures. So these are the objectives of our talk today, and let's talk about the anatomy. The talus has several parts: head, neck, body, 2 processes, that is posterior and lateral processes. It's a truncated cone the anterior part of the body is wider than the posterior part, and the neck deviates 25 degrees medially and inferiorly, which is very vulnerable for the neck fractures. There are no muscular attachments. 60 to 70% of the talus is covered by articular surface, and because of this, this is a precarious blood supply. It's mainly supplied by posterior tibial artery and also supported by anterior tibial artery and peroneal artery. Miller in 2012 has told us about some critical points. Especially this is very helpful when we are fixing the talus fracture. He mentioned about the talus neck, sinus tarsi, the posterior tubercle, and also the medial talar body. This is the picture of the blood supply of the talus. We are going to talk about the talus neck fractures, body, head, lateral process fracture. And as you can see, the neck fracture is the most commonest, and the diagnosis is basically from the history, and it's always associated with polytrauma, so please follow the ATLS protocol. Hawkins classified the talus fracture into 4 types. Type 1, undisplaced, and AVN rate is about 0 to 13%. Some people say that it is very rare, basically because if you can see the fracture, it is probably displaced. That's what is the idea. Type 2 is displaced fractures with subtalar subluxation or dislocation. The AVN rate is increased to 20 to 50%, and this is the most common type. Type 3, there is a subtalar joint and the ankle joint is dislocated, and there is an AVN rate of about 83 to 100%. Cannell in 1974 added Hawkins' 4 classification, which he says that when there is a talonavicular dislocation, and also any other type of talus fractures which were not listed earlier. So in talus fracture, neck fracture treatment, the goals are we need to emergency reduce the joint, stable internal fixation, try to clean up the subtalar joint, and choice of fixation depend on personality of the patient, personality of the fracture, and the personality of the surgeon. In type 1, we can treat it non-operatively by below knee plasters and non-weight bearing. But if you want early mobilization, we can fix it with percutaneous screws. Hawkins type 2, 3, 4 are always open reduction internal fixation. Whether you want to fix it anterior to posterior or posterior to anterior, we will discuss about the plus negative points, advantages and disadvantages about that. Approaches are, we can approach the talus from anteromedially, anterolaterally, posterior approach or combined approach. So what are the advantages of anterior to posterior screws? So when you open up the talus from the anterior, you can see the whole of the neck. So it is a direct visualization. So it avoids any kind of iatrogenic damage. Disadvantage, it is not perpendicular to the fracture, so the compression or fixation will not be as good as from the posterior side. Some of the paper says that it is less strong when you fix it from anterior to posterior. However, ATIA in 2007 has done a biomechanical study, and he told clearly that there was no difference. Advantages of posterior to anterior screws, they say it is biomechanically strong, but we know that it is not true, and the screws can be placed perpendicular to the fracture. The disadvantages are indirect visualization of the fracture and the possibility of cartilage and nerve damage. Coming to the talus body, it is basically because of the axial loading, and the incidence is about 25% of the talus fractures, often associated with polytrauma. Sneppen has classified into 5 subtypes, and the treatment strategy and the outcomes are largely similar to the neck fractures, apart from we might need to do the more frequently we need to do the medial and lateral malleolus osteotomy to approach the body. Talus head fractures, it's less common, and it is basically because of the axial loading from the big toe onwards. And it's usually late presentation with talonavicular arthritis, and you need to have high index of suspicion. You can approach this from the dorsomedial or dorsolateral depending on the fracture pattern, and patient usually will have some kind of malunion, and they have talonavicular arthritis, which might need to be addressed by talonavicular fusion or triple arthrodesis. Lateral process fractures. This is called as snowboarder's fracture, and it is a unique structure which articulates with both the fibula and the calcaneum. It's the most frequently missed fracture, which is about 33%. And McRoy and Bladin has classified into 3 types, whereas type 1 is a small chip fracture, type 2 is a large fragment fracture, and type 3 is a comminuted fracture. They were saying about the V sign, which is that one. In this picture, on the left-hand side, there is a screwed up V, whereas after fixation, you can see that the V is restored. So that's what you need to look for when you are looking for the lateral process fracture. In type 1 or 2A, which is undisplaced, you can treat non-operatively, and whereas type 2B, which is a displaced fracture or comminuted, you can do the fixation, either fixation or excision. The outcome of the lateral process fracture, if you treat them operatively, the American Academy Foot Ankle score and the reoperations are definitely reduced. Coming to the posterior process fracture, posterior process articulates superiorly with the calcaneum and inferiorly with the talus. It occupies about 25% of the subtalar joint. There are 2 processes, and in between the 2 processes is the FHL lies in between there. It's again high index of suspicion. You need to think about whether you have a posterior process fracture or not. If the medial process of the posterior process fracture, it is called saddle fracture, and if the lateral process is called Shepherd's fractures. Untreated avulsion do poorly. However, we don't need to lose our sleep, basically because the untreated fractures can achieve a comparable good long-term treatment if treated late by excision. Extruded talus. It's most devastating talus injury, more common because of the RTA, and always poor prognosis. Historically, we usually were doing talectomy and arthrodesis or primary arthrodesis. Since Smith et al. And Burston et al. Has published the papers in 2006 and 2010, they recommend to reimplant the talus after washing the talus in some kind of antibacterial solution. The benefits of reimplantation is because you are recreating the hind foot shape, mechanics, and the bone stock. The disadvantage is the infection. So what do? We wash the talus, put it back in position, fix it with K-wires, and non-weight bearing for 8 to 10 weeks. Sometimes it can revascularize. I think we have to keep our fingers crossed. But we know that it can get infected, or it goes into AVN. If there is any AVN, we have to think about the salvage procedures, which we have to prepare the patient right from the beginning. The complications of talus fractures are numerous, and in conclusion, talus fracture is a rare, high-energy injury, and high index of suspicion should be there for the posterior process fracture and the lateral process fracture. RF restores articular congruity and alignment. Outcome depends on the personality of the fracture, personality of the surgeon, and the personality of the patient. Thank you.
Thank you, Krish, for staying on time. Thank you. May I request Dr. Gaurison from Singapore to talk on fractures of the calcaneus. Thank you, sir.